Hi, I'm Lisa Nainggolan with theheart.org, and I'm here today with Dr. Renu Virmani of Gaithersburg, Maryland, and Dr. Sunil of Duke University to discuss the findings of the Symplicity HTN-2 trial, which is a trial of catheter-based renal denervation for resistant hypertension, a very novel twist on an old idea, I believe, whereby the sympathetic nerves are ablated with radiofrequency ablation, and they have seen in this trial some quite impressive reductions in blood pressure, but there are also obviously some concerns. So perhaps you'd like to start off, Dr. Virmani?
I think it's very interesting. I have to say that, you can reduce blood pressure by denervating the nerves around the renal artery. And they've done it in a clever way by using RF ablation. However, as we all know, RF does cause necrosis of the vessel wall or kill cells in the vessel wall. And therefore, it'll have some effect and it'll increase neointimal formation. But they're not doing it as circumferential in one spot. They're doing it in spot areas which are at about 90 degrees from one another or slightly less. And they have been very successful. So far, they haven't seen side effects.
Yeah.
But the only thing that I am concerned is why then 16% of patients did not respond. Why the rest of the at least 36% were responders with greater than 10 millimeters of mercury drop in pressure. So I would like to understand why not everybody responds.
I think that they believe maybe the denervation didn't work completely in those 16% of patients, but that obviously needs to be investigated.
I mean, you could improve this by doing a much more systemic way of doing it, rather systematic way of doing it, rather than the way they did it. Is just a spiral catheter in a sense, which has RF ablation on it, and that they just flip it around. And it's not done in a, controlled manner. And you could do it in a controlled manner, and there are companies that are trying to do it in a much more controlled.
So that it was consistent in each patient.
So that it would be consistent, and you could go through the circumference of the artery in a spiral manner rather than in one spot. Therefore, you can get better results in the long run. It could be that will make a difference.
Do you agree? You're an interventionist,
I think
Dr.
I think you said it right. I mean, these results are impressive. I think we have to be very careful to temper our enthusiasm in a field where we have been met with frustration as clinicians. So there is, I think, a real temptation to overinterpret these results, and we have to be very, very careful. Remember that this is a device-based strategy. So this trial was done in centers that have experience doing this. This is a very novel procedure.
Of course.
And it's a very new type of device, although the idea is old. The other thing I think is, which speaks, I think, maybe even more broadly to the device arena in general, is that, these trials are very small. And even if you look at a pivotal trial design that you would really need to change practice in a patient population where the mortality and the morbidity rates are very high, you would need lots of patients. And I think we learned a long time ago that hypertension or high blood pressure as a surrogate endpoint is probably not the appropriate way to look at outcomes. So I think this is a very preliminary foray into this type of technology. I think there are reasons to be encouraged, but I have lots of reasons to be skeptical, and I would like to encourage the clinical community to remain objective until we have better data.
Mind you, these were people who were on 5 medications, and they were then made to they were randomized to those with or without treatment.
And in fact, I think the people in the control group will get the ablation. They were just going to be delayed by 6 months to be used as a control group. That was my understanding.
I see.
They were out of options, basically.
Yeah, when you're taking 5 medications, you will agree with me, that's a lot of medications to reduce your blood pressure, bring down your blood pressure. So if you can help by 10 millimeters of mercury, by reducing your pressure by 10 millimeters, which may be quite significant.
I find this amazing. I'm actually the skeptic, and Dr. Virmani is not in this case, but which is amazing. I'm glad you're getting this on film.
I mean, their mean BP was 178, their systolic.
But although the investigators said they didn't aggressively control the medications in each arm because they wanted to test the effect of the device itself.
Yeah, it was on top of medication.
It was on top of medications.
It was on top of medications.
And hypertension trials are tough to do. They are tough to do. So I'm enthusiastic,
but skeptical.
but I am skeptical.
They were able to reduce some of the meds, though, of some of the patients because they didn't need as many and they didn't
Sure.
need as high doses. So.
But, you know, when you consider what a large population of the world has systemic hypertension, I don't mean to that it should be used on everybody. Don't get me wrong. I would be totally against that. But I think those who are resistant to, you know, usual medication, 5 medications, and are still having systemic hypertension, then I think those are the candidates. I would never suggest in the large population that somebody who has mild hypertension, you go and have this procedure. Absolutely not.
I guess it will be interesting to see the results from the US trial that is going to begin, again, not in a huge number of patients, but 300, and doctors here like to see trials done in the US.
And again, I think, you know, there are trials and there are trials, and I think Dr. Virmani is really the one who's kept us sober, particularly in the drug-eluting stent world. Remember, trials are never powered for safety, and safety is always an issue when you have procedures. So 300 patients is a great start. I worry a little bit if I were to project 10 years into the future, you know, what's going to happen to this technology when it diffuses into centers that maybe don't have a lot of expertise, and we start seeing thousands of patients getting treated inappropriately or appropriately. Maybe we'll see a safety signal that comes out. I also worry about this issue of scarring and stenosis.
How do you think, as an interventionist, the procedure sounds fairly simple? I mean, they told me it takes 30 to 40 minutes.
Well, you know, simple is always good in the interventional world, and I think angioplasty has evolved to the point where, as many people have told me, a monkey could do it. So, you know, simple is always good, and I think, you know, obviously I'm myself as I'm an interventionalist, I'm always interested in catheter-based interventions. But I think the one thing we've learned over the last 5 years with the publication of the safety concerns with DES, the COURAGE trial, is that just because you can do something doesn't mean that you should do it. And that's why I think the application of this technology is going to have to be in a very sophisticated way. We need to target the appropriate patients, as Dr. Virmani said.
A slow trickle rather than a...
But I also want to see that the renal artery is checked for.
Yes.
How are they going to look at the renal artery if you've done any harm?
Right.
It's not only just that they, you know, the blood pressure rises suddenly. That's not the way I want it.
Absolutely.
I want to do it non-invasively and be able to say maybe by multi-slice CT to be able to follow it 1 year to see what is happening to the renal artery. I would want to see that.
And apparently it's quite a painful procedure, so you have to use analgesia. They're discovered with the first patient.
That's interesting. That's interesting. We've seen that with renal artery stenting, for example. When you deploy the stent, patients will often complain of back pain. And that is a significant issue, I think.
I mean, I think Dr. Esler himself said that he was concerned about these non-responders because it isn't the kind of thing that you want to put somebody through if there is going to be no benefit for them, even.
But I wish there was some other way of knowing whether these patients are going to benefit or not benefit. Rather than, you know, hit and miss. You know, it's like, you know, putting drug-eluting stents when you know you probably don't need it. It's the same thing. If you don't need the procedure and it's not going to work, I don't want any patient to undergo this procedure and it doesn't help him.
So I think we're all in agreement here. Very promising initial results. Looking forward to perhaps seeing a few more 100 patients, but then still a very long way to go before.
And also to know long term. How long does this effect last? Is it permanent? Is it temporary? We certainly can say 6 months at last. And I think from their first in man, they seem to have indicated that it is longer than 1 year that it lasts. So we need to look for that.
Antihypertensive efficacy lasting up to 2 years in some of the patients. But of course, long-term results are always important. Thank you very much.